In CardioSource World News, we've done news stories. There was a cover story in CardioSource World News Interventions, and right now we're talking about renal denervation. And to the extent that it is news, and it always is, we really owe a lot to the SYMPLICITY HTN trials. And I am with Professor Henry Krum, Monash University, Australia, at ESC. What is new?
So what's new is that we have 36-month data from SYMPLICITY HTN-1, and we have it in all patients who got to the 36-month time point. And that gives us information about efficacy in terms of the durability of the blood pressure response, and also gives us information about safety, the fact that there have been very few adverse events, long-term safety signals from the 36-month experience. In
3 years, what have you learned?
I think we've learned quite a lot. Really, from the very first patient, we had no idea what to expect. We learnt that these patients do experience pain during the procedure, and that's been an evolution into how to manage that adequately. We've learned a lot about the sympathetic nervous system from the experience, and I think that has spilt over into other disease states where denervation has potential. And I think we've learned a lot about tracking safety of the procedure over that time point.
Has the clinical procedure evolved at all over the 3 years?
Dramatically. So the SYMPLICITY HTN-1 experience was with a single electrode catheter. They're effectively now redundant, vintage type catheters, and it's now all about the multi-electrode approach. And as you know, a huge number of vendors have come in with such type catheters. Beyond radiofrequency ablation, there's now ultrasound-guided catheters and a whole series of other funky approaches which make this a really interesting field and a highly evolving, rapidly evolving field as well.
Now, what is next? What do we still not know that we hopefully will know? And I know we have SYMPLICITY HTN-3, or 2 rather, still out there.
Yeah, so 2 is still following up patients, and there should be 36-month data in SYMPLICITY 2 in about a year's time, or maybe less. There's SYMPLICITY 3, and to me that's a critical study because it's taken all of the things we learned in SYMPLICITY 1 and 2 and have really applied it to a very rigorous trial design to really, I think, address the question once and for all as to the benefits against a control group in a refractory hypertension population.
You know, last year at the ESC meeting, one of the posters here was talking about the fact that they were looking at patients who had been recommended for renal D, and one of the things they found is that there were a lot of those resistant hypertension cases that had other things that hadn't been detected up to that point. How do you make sure you get the absolute right patient for this procedure?
Yeah, I think it's a terrific and really important question, and speaks to the fact that we've probably been under-managing these patients up until now, and you've probably seen manuscripts that have emerged which show that if you take a resistant hypertension patient, and I put these in parentheses, and actually carefully look at them for secondary causes and very carefully up-titrate their management. In fact, there aren't that many. Still a huge percentage of a very large problem, but as a percentage of the actual population you're starting with, this diminishes very rapidly into those patients who are truly resistant and thus would truly benefit.
I was out at Mount Sinai about a week ago, and they were talking there about the fact that we have too many patients who are on essentially homeopathic doses of some of these key medications, and we really need to get the patients to the level of medication that was used in the major clinical trial.
Yeah, look, we're all guilty of that. Doctors like to have patients on drugs, multiple drugs. They feel they're doing things correctly in doing so, but that's really just the start of the hypertension management story, not the end. And it's all about up-titrating to the highest tolerated dose, if not the target dose.